continuing on with this. So, baroreceptors controlled by negative feedback. You have pressure receptors in the internal carotid as well as the aorta, which will detect blood pressure. They monitor the degree of stretch either in the right atrial chamber, going into the aorta, or into the the carotids. I'll wake up. I had a rough morning this morning. It's only going downhill from here. So again, you send that information to the brain, and the brain detects it. And I think I have a little feedback loop up here. Ah, yes. So if the blood pressure is going up too high, we stretch out the arteries. The baroreceptors pick that up and send information that goes to the brain. So the cardioinhibitory center is stimulated, vagal tone increases, and that causes parasympathetic input to be sent to the heart, so the heart rate goes down. You also inhibit the vasomotor center, so that reduces its sympathetic input to the smooth muscle in the blood vessels. That causes vasodilation, and that also will help to ultimately reduce blood pressure. So that's how that all works. That's why if you're massaging someone and you're working on their SCM in the neck, you have to worry about activating those baroreceptors inadvertently, and they'll send information to the brain, and the brain thinks that you've got high blood pressure when you really don't, and now it'll these reflexes kick in, and then you drop the blood pressure, and the person feels like they're going to faint. So that's not fun. Gently care. We don't want to do that. We want to be nice. So that's that. Chemoreceptors are looking for changes in the amount of carbon dioxide, oxygen, and hydrogen ions in the bloodstream. The big one here is carbon dioxide. So again, these are also found in the carotids, in the aorta. They're stimulated by hypoxia, which is a lack of oxygen, acidosis, too much hydrogen ions floating around because that drops the pH too much, and hypercapnia, which is excess carbon dioxide. These receptors ultimately influence respiration rate. That's why they tell you if you're hyperventilating, breathe into a paper bag, because if you do that, you'll inhale more carbon dioxide, and that eventually slows down your breathing rate. Same type of an idea here. So it ultimately controls the number of breaths you take per minute and how deep each breath is. It also regulates blood flow to the brain. If your CO2 levels rise in your cerebrospinal fluid, that dilates blood vessels that are within the brain to bring more oxygen into the brain tissue. Right, salute. Yay. Look good? Pause for a moment.
Well, you better hold back today.
I am not holding back. I am just sucking down on the Luden's chill cough drops like there's no tomorrow. That's the only way I'm going to make it through today. Okay. Now, shut them off. So I went through this. Hormonal regulation. Oh my gosh, it's the renin-angiotensin-aldosterone system. It's one of my favorite systems of all time. So, with our renin-angiotensin-aldosterone system, we ultimately release angiotensin II. That's a potent vasoconstrictor. So when we constrict the smooth muscle in blood vessels, we end up ultimately raising blood pressure. In fact, it's 4 to 8 times stronger than norepinephrine when it comes to raising blood pressure. How do you like that? Also stimulates thirst. So you bring in more water, that's going to increase blood volume, and that increases blood pressure. And then it's going to cause us to release aldosterone, which will tell us to conserve sodium. If you conserve that, you conserve water, and then that increases blood volume and blood pressure. it'll get you to release ADH, and that causes you to reabsorb more water in the kidney tubule. That increases blood volume and blood pressure. See see where we're going with that? We're increasing blood volume and blood pressure. Because for some reason, blood pressure has been dropping to places we don't want it to go. We want to raise it. Epinephrine and norepinephrine cause widespread vasoconstriction, except locally to blood vessels that are going to heart muscle and skeletal muscle. Because in those areas you want to bring more oxygen and more ATP production for those areas. ADH, you're going to conserve water. That increases blood volume and blood pressure, like I said. We have a hormone that antagonizes that muscle, or that hormone, which is called atrial natriuretic peptide, ANP, as well as BNP. Don't ask me why they call it brain natriuretic peptide when it's made by the ventricles. I don't name these. But the natriuretic peptides are released if you've got too much water in the bloodstream, and that helps you to get rid of excess fluid and drop blood pressure if it's too high. So the natriuretic peptides antagonize ADH, aldosterone, epinephrine, norepinephrine. Finally, your erythropoietin, EPO. That'll increase the volume and viscosity of blood because you'll be making more red blood cells. Remember viscosity, one of those four factors for resistance? Yeah. So these various ways that we can hormonally regulate or tweak our blood pressure. Yekel? Yippee? Kaye. Okay. Now, autoregulation. This is what we're relying on initially, and if this doesn't work, then we need neural or hormonal input to fix things. So that's the ability of a tissue to adjust its blood flow to match its metabolic requirements, its metabolic rate. And this is especially important for the cardiac muscle, the brain, and skeletal muscle tissue. But it's found everywhere. And this is caused by either physical changes like warming. Where blood goes, heat follows. So if blood vessels vasodilate, they bring more blood to an area locally, and that's going to heat the area up. If vessels constrict, less blood flow means cooling. You also have, the myogenic response. And I find about the best way to describe this is it's kind of like Starling's law of the heart for smooth muscle in the arterial walls. Because if blood is going through an arteriole with a great force, it stretches out those walls, and then those walls rebound with an equal strength. Whereas if the blood is traveling through less forcefully, it doesn't stretch those walls as much, and they don't rebound as much. So it's kind of the same thing about, if I push you, you push me back at the same amount of force, but in this case, we're talking about the walls of the arterial wall in that respect.
So no matter what, your body will try auto-regulation. If that does
Yes.
not work,
Then you rely on neural and hormonal methods. Yes. Certain chemicals can also play a role in this dance. So vasodilators will cause smooth muscle contraction, be they various electrolytes like potassium or hydrogen ions, nitric oxide, et cetera, et cetera. There are also a couple of vasoconstrictors to think about, like a serotonin and some prostaglandins. So, again, you could have, for example, paracrines. Remember, those are substances that are secreted by the cell that has an effect on a cell that's very, very close by, and that can get, you know, the smooth muscle in these vessels to constrict. So, chemicals or physical changes can get this autoregulation to occur. Yay? Give me food. Okay. Pulse. A traveling pressure wave caused by the expansion and recoil of the elastic arteries after each contraction of the left ventricle. You can feel it in the following arteries that I have listed. The superficial temporal, you have a pulse in the temporal region in the head, as well as a facial pulse, which I always find hard to locate. Common carotid is another good one. Brachial artery, femoral artery, popliteal behind the knee. There's the one in the ankle, dorsal pedis, like talk, and the radial, which is the most common. Normally, this is supposed to equal heart rate, so 70 to 80 beats per minute, give or take a bit. Tachycardia is an abnormally rapid heart rate. Bradycardia is too slow.
Where's the one in the face?
Where's the what? Huh?
The pulse in the face?
The facial artery somewhere, I want to say around in the cheek area, but I've never been able to locate
Well,
it.
I was wondering if it was closer to the sinus.
Yeah, I've never been good at finding that one.
Could you feel it right here though?
I don't think that's that close. No, I think it's somewhere more for out here, I think.
Underneath the body, not
I would guess somewhere out in here, but not that close to the eyes. Not in here. I don't think it's somewhere out in here. That's something I have to look up.
Okay, arteries is blood flowing out
Yeah.
towards the body, and veins is flowing back towards the heart.
Yes.
So when you check the pulse, why are you checking the arteries and not the veins?
Because the arteries, the pressure is much greater.
Okay.
Arteries pressure is much greater. Let me see if I can look up facial artery in here. Probably won't. Probably will fail me. Come on. Fenestra, faculty.
That's the medical dictionary? Or
Yes,
the
it is my
Human Body
wonderful medical dictionary. Factor. Facial expression. Maybe if I look at pulse. Hyrexin. Bless you.
Dictionary? You turned the AC on?
Purkinje. Wanted. No. Of course, it's got everything but facial pulse. It's got femoral pulse. Google it.
I think it's under the sinus, but
And I mean, it could very well be.
because I swear I could feel something right here, and then I'm looking over here.
That might be a
And
sinus headache
seeing
pattern.
I'm seeing an artery right in where I'm feeling.
Well, no, Aldine is here. So we're waiting for Victoria,
Put your
Max, and Tiffany.
feel like Charlotte.
Yeah, well, Tiffany, I know Shiler's out. She texted me she's sick. Oh, Tiffany, didn't she say she wasn't going to be here today or something?
Is that the blonde girl that's a snack store?
That's the glasses girl, yeah.
She's in Iceland, okay?
Oh, that's right, Iceland. She's partying.
And my neighbor, she's in Texas.
Uh-huh.
I'm telling you, I've located it. I'm the best doctor.
Okay. Well, then maybe it is over there.
Where? Now I wanna know.
Where did you locate it?
I'm telling you, you can feel it right here. I feel a pulse.
Wow.
Yeah, I'm not sure.
You're feeling over there. I always thought it was farther out over here. That's something I have to look at.
I'm just going based off of what you taught me on
Ah.
where the arteries are.
We'll figure that out a little bit later. Let me put this back before I lose it.
But you could feel one over here too, because that's where
Okay. Well, measuring blood pressure. We've got our blood pressure cuffs back there, so you could actually play around with those in lab today because we've got the time for that. The sphygmomanometer is what we use, and what we do is we inflate the cuff enough to temporarily compress the brachial artery. And then you take a stethoscope and stick it under the cuff, and you listen as you gradually deflate that cuff. And eventually, the blood will start to flow back through that artery. And the first sound you hear with your stethoscope is when the blood has pushed through and it's starting to go through that reopened artery. And then you continue to listen. And when you finally don't hear anything, that is recorded as the diastolic blood pressure. So the first sound that you hear is the systolic. When you don't hear anything else, it's diastolic. And that's called the sounds of Korotnikov. I can never pronounce that. But anyway, that would be your blood pressure. Typical blood pressure is 120/80, although they like to see 110/70. Systolic hypertension is considered above 140 millimeters of mercury. Diastolic is considered anything above 90 millimeters of mercury. Diastolic hypertension is considered worse because if your pressure is that high while the heart is in its relaxation phase, that's especially not a good thing. We don't like to see that. And the pulse pressure is simply the difference between your systolic and diastolic pressures, and that tends to be about 40 millimeters of mercury, give or take.
Why is diastolic worse?
Because if you're that high while the heart's in the relaxation phase, that's really a bad sign.
So they don't both have to be high. You could have high systolic or high diastolic.
Yeah, but people tend to see, but I mean, you could see someone with, let's say, 140/85. You know, that would definitely be hypertension on the systolic side. Diastolic, it's higher than they would like to see, but not quite officially hypertension yet. But, yep. Okay. Is this the right slide? Did I hit the right button? Okay. Okay, 1, 2, just don't mind me. Okay. I want to see how far I had to go before I got the shock. Okay, so cardiovascular response to exercise. At rest, our cardiac output's around almost 6 liters of blood per minute. Now, cardiac output is the amount of blood that the heart pumps out on a minute-to-minute basis. Since we tend to have about 5 liters of blood in our system, we're definitely pumping the entire volume through our system and a smidgen more to spare on a minute-to-minute basis. So the heart is quite busy even when we are at rest. During light exercise, we see 3 things. We see extensive vasodilation because we are increasing oxygen consumption to skeletal muscles. So we better get more blood, which means eventually you get more oxygen and more ATP production to those skeletal muscles. So your peripheral resistance in those areas drops, capillary blood flow increases. Your venous return is going to increase because your skeletal muscles are contracting and they are squeezing on the veins that they are surrounding, and that helps to push blood back up to the heart. And also, the respiratory pump, as we are inhaling and exhaling more deeply, that puts pressure on the veins in the thoracic and abdominal cavities, and that helps to force blood back to the heart. Cardiac output's going to go up because venous return goes up. And also there's something called the atrial reflex. If more blood returns to the heart, it's going to stretch out the atria more, and they're going to respond with a greater than normal contraction. So it's kind of like Starley's law for the heart, but for atria instead of ventricles. So all of that helps to increase blood flow, but at this point, White's max, there is no massive sympathetic activation yet. So we're just exercising gently, so to speak. There's Max. However, let's say we want to start really sweating bullets. Heavy exercise. Now we activate our sympathetic left nervous system and also our cardiac and vasomotor centers in the brainstem. You can see our cardiac output go up as high as 25 liters a minute. So it's really, full throttle, pedal to the metal kind of a scenario. We also will see our vasomotor center redirect blood flow so that we won't send as much blood to non-essential organs like your GI tract, your kidneys, because you want to get as much blood to your skeletal muscle as possible. They're the ones doing all the work at this time. They have a premium on oxygen. We also want to increase blood flow to the skin because where blood goes, heat follows. When you exercise, you generate enough heat to boil a cup of coffee. So you better get rid of that heat, otherwise if you don't, you get heat stroke. So that is why we dilate those blood vessels, so we bring heat to the surface and get rid of it. And blood flow to the brain should remain constant. We never want to sacrifice blood flow to the brain. It's not fun. If you ever saw on, Mutual of Omaha's Wild Kingdom or National Geographic or whoever you watch the cheetah or the leopard, they're trying to track down the gazelle and they run like hell after the gazelle, and then after a while they gotta stop because they didn't catch the gazelle. They didn't stop because they got tired. They stopped because if they continued, they would die from heat stroke. So they can actually get so physically active that they no longer have the ability to whisk away excess heat from their body, and if they continue to run, they'll just drop dead of heat stroke right then and there. So that's why they have short bursts, and then they have to just calm down, sit under a tree or whatnot, and just chill out for a while before they are ready to do it again.
They must be very in tune with their sympathetic.
Oh, absolutely. So it's not because they get tired, it's because they don't want to get the heat stroke. Kind of interesting.
That is
Interesting too. Interesting.
Is that
Yeah.
gonna be extra credit?
Oh, I don't know, maybe. Got me. Wait till the next test when I draw my famous fish picture on the board. You'll love that. But that's something totally different. Now, during this super heavy exercise, sympathetic stimulation will basically constrict almost all the blood vessels in the body, except those of your exercising skeletal muscle. Because those you want to dilate to bring more blood flow locally to those areas, because more blood means more oxygen means more ATP. So we dilate blood vessels to those areas, we constrict everywhere else. Interesting little tidbit. They did a study, because there's always someone somewhere doing a study, and they had people imagine that they were exercising. How do you like this? They would imagine that they were exercising, and they would, I don't know how they had them do this, but they actually had them imagine for like 30 minutes at a time that they were doing strenuous exercise, and they did this like 3 or 4 times a week. And at the end of about 6 weeks, they measured their muscle mass. And their muscle mass increased by 10%, even though they never actually did anything.
I'm about to
No, it's because the body is actually preparing you for that increased level of activity that it's expecting that happens to never come. So if you actually have the discipline to meditate that you're actually exercising, even if you don't do anything, you actually can increase your muscle mass. So sleeping like I do, taking naps, that won't help with the muscle mass, unfortunately. But if you actually have the discipline to sit there and imagine you're on the treadmill or you're on the stationary bike or whatever for like, half an hour at a time, 3 times a week, that's almost as good as actually doing it. But who would actually crazily do that? I don't really think anyone. Well, I mean, I believe it, but I don't think anyone's nuts enough to really try and do it. I mean, if you're going to actually think about it, you might as well do it. It's easier to do that. Concentrate about doing it for half an hour, right? But anyway, yeah,
The other day, I couldn't breathe, And then I just put on those binary beats or whatever, binaural beats or whatever.
The binarials.
Yeah, those beats.
Uh-huh.
And then I was able to, it was like I put on a specific one just to be able to breathe, so that my brain could know what to do, and then I woke up, I was good. The brain is really powerful.
Amazing. It's almost as good as Luton's Quattro.
You should just put on those beats, man.
Might
Yeah,
have
we
to,
got
I gotta
OD
resort
on
to something.
He's about to get pounded.
Yes. Got that. Yeah, huh? So, nice little picture here. They got a picture of someone just chilling out with a beer on his recliner. That's an ode to me. And then there's someone playing soccer. I got to watch because the last time I showed this slide, I made the errant comment that soccer was not really a sport, and then someone nearly killed me. Joke, that's a joke. Even though I'm not a soccer fan, but it's a joke. Hockey started last night, but anyway. So here, when we are reclining, we are redirecting our blood flow to the intestines because I guess the body's probably expecting you to stuff your face while you're watching your favorite TV show. So you've got to bring more blood to the intestines to absorb whatever junk food you're ingesting. Whereas if you're actually exercising, now we do the opposite. We redirect the blood to the legs because here we're running around on the soccer field. So our body can do our little mid-course corrections depending on how active or how passive we happen to be. Oh yeah? Yeah.
Oh, yeah.
This is a great slide to know. Hint, cough, wink. Cough, wink. Hint. Shock. Failure of your cardiovascular system to meet cellular metabolic needs. 4 different types, depending on the source. They might categorize these a bit differently, give different names. We're going to go with what we got here. So the first type of shock is hypovolemic, due to decreased blood volume. So you're talking about something like hemorrhaging. You have some type of injury, you got shot, you got stabbed, you got into a car accident, you fell from a very long distance and had a sudden stop. That would be a situation where you would have hypovolemic shock. Cardiogenic shock, due to the failure of the heart as a pump. Classic example would be congestive heart failure. So if you have congestive heart failure, the heart just doesn't want to do its thing. That's cardiogenic shock. Vascular shock is if you have inappropriate vasodilation, which leads to a massive drop in blood pressure. That's anaphylaxis. So you're allergic to peanuts, you're allergic to bee sting or something like that. That's what we're talking about there. And then finally, obstructive shock is due to blockage of blood flow. So if you had a blood clot somewhere that's blocking off flow to the tissues distal to that blockage, that would be obstructive in nature.
For vascular shock, is it only like allergies, anaphylaxis, or?
I mean, it could be something like toxic shock syndrome would be another case. That would be massive vasodilation as a result of a toxin that certain bacteria produces that could cause that. That's something that you can talk about in micro.
Yeah, we.
Uh-huh.
we're talking
So
about-
that
I
would
don't
be
know
another
which one.
example of that, yeah.
I read it.
Yes?
So just know like the different types of shock and like examples of them.
We actually had, who is it? What is it? We had our lab yesterday, we're doing alpha, beta, and gamma hemolysis with the sheep's blood agar. You didn't talk about that yet in micro. But people were doing throat swabs. You
Yeah.
couldn't believe how many
Yeah.
people in our class who were strep carriers. I'm looking at all these plates, they're all positive for strep, and I'm like, I don't even want to talk to any people.
Serious?
Yeah, we caught them up back.
Oh, they didn't call, they actually,
We did not
throw
do
the
the
swab
swab.
and they put it on there and then they incubated. I'm like, oh my gosh, this could do that. Yeah.
We did the blood out.
I get stressed.
Oh, yeah. So we're only missing Victoria. More about shock. If your blood volume drops more than 10 to 20%, or if the heart can't raise the blood pressure sufficiently, That's a big serious problem that can be life-threatening. Signs and symptoms. So a systolic blood pressure below 90 millimeters of mercury, Hg is mercury. Rapid resting heart rate, if you have a weak, rapid pulse, cool, clammy skin, confusion, because you're not getting enough blood flow to the brain, altered mental state. Decreased urine flow because blood pressure is the driving force behind urine formation. You become very thirsty because you want to try to absorb more water to increase the blood volume and then blood pressure. So that would be another sign. Low blood pH, you're becoming acidotic, possibly even nausea. So those are signs and symptoms of the shock.
Hold on,
Yes.
just please
Oh, no rush. On a roll. I'll just suck on my coffee. So now we had a great time. Oh, fantastic.
Oh, yeah, we got a long time left.
Not yet.
Party
So
zone,
it's only
the
gonna get
party
better.
zone again, sorry.
Only get better.
Okay.
Okay. All right. How do we compensate and reverse this process? Renin-angiotensin-aldosterone system is one of the major ways we try to deal with this. You want to increase systemic vascular resistance, which is SVR. If I increase the vascular resistance, ideally the body's going to respond by increasing blood pressure. Also, I want to conserve on fluid, which will increase blood volume and blood pressure as well. So these factors, they potentiate each other. They're synergistic. You know, whole is greater than the sum of its parts. ADH, you want to hold on the blood volume and blood pressure. Well, blood pressure will go up because the blood volume goes up. Sympathetic activation, vasoconstriction will bop up your blood pressure. And then finally, I could release local vasodilators to increase blood flow to certain areas, but this is a situation where I'm walking a tightrope. If I do that too much, it's going to have a negative effect. You have to do that in just the right areas to make sure that you, for example, maintain adequate blood flow to places like the brain, but at the same time, you don't want to vasodilate systemically too much because that's going to drop blood pressure even more. So you've got to have a happy medium. Very, very important that you, if you vasodilate, you do so very carefully and very specifically. But a lot of times the body can't actually do it as specifically as we want. Then when it's trying to tweak a little bit, it actually could make things worse. So you've got to be careful with that.
What was the first word on the SVR that you said?
Systemic vascular resistance. Oh yeah. Cool. Hey, we're getting a thumbs up. Hey. These are two good slides. Pulmonary versus systemic circulation. The big thing you want to know with these is that in the pulmonary system, arteries carry deoxygenated blood, veins carry oxygenated blood. But in the systemic system, which is everywhere else, that's reversed. All this bit about, you know, who's got less elastic tissue and thinner walls and less resistance or whatever, that don't worry about that. What I want you to know is which vessels carry oxygenated versus deoxygenated blood. And when you say that, it's relative. Oxygenated blood is essentially 100% saturated. It's carrying as much oxygen as it can fit on its own hands. Whereas deoxygenated blood is probably still about 75% oxygenated, 75% saturated. Okay? So, the pulmonary arteries are the only arteries that carry deoxygenated blood. Whereas pulmonary veins are the only veins that carry oxygenated blood. That's why in the heart models, pulmonary veins are red, but the pulmonary trunk and pulmonary arteries are blue. It's not because they're trying to confuse you. That's just because if you're red, you carry oxygenated blood, but if you're blue, you carry deoxygenated. Okay? So again, systemic circulation, it's switched.
That's really all you want us to know about.
That's what I want you to know about that. Okay. Wait. Oh, Wes. Everyone's sneezing. All right? Okay. Another example of a portal system. The first one I talked about was when we're talking about the hormonal system, and we were talking about the connection between the hypothalamus and the anterior pituitary. Now we're talking about a connection between the small intestines and the liver. So we have a portal vein. Oftentimes on these big pictures, the portal vein, hepatic portal vein, will be pink
Purple, right?
or purplish. Let me look on this because I can never remember and my eyes are really bad. But this pink vessel right here, that's the hepatic portal vein. And that's why they have it pink. They want it to stand out that way. So with the portal system, you have two capillary beds in sequence. So you don't go from arteries to capillaries to veins back to the heart. You go from artery to capillary bed 1, then to capillary bed 2, and then through veins, and then back to the heart. With the hepatic portal system, you're going to take oxygen-poor but nutrient-rich blood from GI organs, especially small intestines, to the liver. So the liver can get all of its little hands on the nutrient-rich blood. So everything that you're absorbing from your diet, the liver gets first dibs on. Whether it's carbohydrates, your simple sugars, amino acids, fatty acids, triglycerides, whatnot. The liver gets first dibs on all this niftiness. Also, the blood can detoxify substances, store substances like fat-soluble vitamins, B12, even though B12 is not that soluble. Never eat polar bear liver. Toxic amounts of vitamin A, it will kill you.
Polar bear?
Yes.
Really?
A totally worthless piece of trivia, but nonetheless true. Yeah. So, oxygen poor but nutrient rich blood going to the liver before it goes back to the heart. That is your hepatic portal system.
What was the thing about what detoxifies store? Like what is doing that? The
Your
liver
liver's doing
is
it.
detoxifying,
Liver's your major
doing
detoxifier
storage
along with the
Okay.
kidneys, but the liver is your major one. Yep. Yeah. So we go here. So here is my beautiful drawing, like this. So my hepatic portal vein is going to take in blood from the spleen, from the superior mesenteric, which drains the small intestine, from the gastric veins draining the stomach, and also the cystic vein that drains the gallbladder. And all that blood goes to the liver before it goes back to the heart. Stomach. Yay, cool? I'm not in any rush, so I don't. We're in no rush here. We're doing well. We're having a good time.
Oh, yeah.
Yeah,
It's a blast.
a blast. It gets better. You ready?
Yes, sir.
You're ready to rock. Now we're talking about Well, one was before. Oh, yeah. See, I'm eventually gonna get to these where this is a good, reinforcement for lab, but, so we're closing in on the end of this. More about coronary roots, or circulatory
Don't
roots.
worry about these.
Oh, this is for the test, not for the lab exam. So for the test, you want to know that the coronary vessels supply blood to the heart as an organ so it can do its job as a pump. The bronchial arteries do the same thing for the lungs. Bronchial arteries take blood to the lungs so they can do their job of oxygen absorption into the bloodstream. You see
So
that?
know
see-
this slide.
Yes, so see the difference there? So coronary arteries are to the heart what the bronchial arteries are to the lungs. Blood going to and from the lungs via the pulmonary vessels doesn't do anything to feed the lung tissue. It's going to and from the lungs because it's picked up oxygen and it's bringing that oxygen back to the heart. That oxygenated blood back to the heart to go to the rest of the body. But if you want to actually get oxygen to the lungs themselves so that that tissue survives, you need the bronchial arteries to do that. So the bronchial arteries do to the lungs what the coronary arteries do to the heart. Make sense?
Mm-hmm.
Good analogy? Yeah, good. Yippee. Cayenne. Whoa. Fetal circulation, again, differs from adult circulation because our lungs are not functioning, neither are the kidneys and our GI organs. They only really kick in after birth. You are going to exchange all of these materials at the placenta via the blood vessels going to and from the umbilical cord. Usually there's no direct mixing of maternal and fetal blood. That mixing only will take place when the placenta rips during labor. So blood cells are too big to be exchanged. So it's the maternal blood that's going to be carting off the wastes and carbon dioxide, but providing nutrients and oxygen. That's what mom is doing all this time with fetal circulation. Okay?
So when the placenta rips, baby gets, it all mixes back and forth?
You might see that, not necessarily. You might.
Like if the baby swallows some stuff or.
No, I just between mom's circulation and baby circulation. That's how mom could be sensitized to the baby's
Right.
baby's blood, foreign blood.
Right. No, I'm just like trying to picture it, like how the exchange of materials would occur.
No, I mean if you're ripping that placenta, that's quite. You know, women can hemorrhage that way too. That's why they have to give them the ergot preparations in order to cause vasoconstriction to stop the bleeding. So if you get that connective system ripping it apart, you're going to see blood spilling and possibly transferring or mixing up in that type of scenario between baby and mom, because the umbilical cord is going to have blood vessels that take blood to and fro from the placenta and to the placenta.
So it's more for the mom.
Well, ultimately, you don't want mom to get sensitized, but also that there might be some situations where you might have some possibility of like a congenital exchange of, like if mom's sick with something, you don't want mom to actually give it to the baby. Sometimes certain infectious agents can cross the placenta, others can't. So you have to worry about what might happen during childbirth. What else we got? Foramen ovale, that's the opening between your left and right atrium. And that's gonna close to form the fossa ovale, and that's supposed to do that within a year after birth. And that takes about 25% of blood from the right side immediately to the left side. The remainder of the blood goes from the pulmonary trunk through the ductus arteriosus into the aorta. That's supposed to close almost immediately after birth to form your ligamentum arteriosum. Yay. Grab another loop. I think I'm gonna,
So the foramen ovale, that's what you said is a hole in the heart if it
Yes.
doesn't close properly, but
Right.
not this ductus arteriosus.
the ductus arteriosus, if that doesn't close, that's another issue altogether, and it's got a name I can't remember off the top of my head, but that's even more serious. Because that's supposed to close within days after birth.
So what is the one that they can see, the foramen ovale, if it's too big? Like, can you see this in utero? Like, do they know that it's gonna be too big before the baby's born?
It would
Sometimes they
still
have,
be,
like-
it should be open before the baby's born, so that, I think you'd probably first pick it up on a stethoscope, and then I would guess you'd use an echocardiogram to confirm how big it is. And then based on that, determine whether or not you want to actually operate to close it.
So this would not be something that, like, they would know that after birth that the baby would need a surgery,
Not
right?
necessarily. In fact, from what I've heard, the larger the hole, the harder it is to diagnose because the sound is not as great. So that's the weird thing. The louder the sound, the smaller the hole.
Well, that makes, right, it's hitting off.
Yeah. Yay. Now, our lovely picture here showing us flow chart of field circulation. I found that somewhere online and popped it on. So, wow, that's great.
Sure don't.
Oh yeah. Do that. Now, rest of these are pictures to get you comfortable with what you're going to have to identify on the lab exam. On the lab exam, you will have to identify left and right. So keep that in mind, full credit. With the aorta, thoracic aorta is above the diaphragm, abdominal is below. Huh?
We don't have a quiz today, right?
No,
Yeah.
next week. Next week's quiz. Week after is the lab exam. So, thoracic aorta above the diaphragm, whereas abdominal aorta below the diaphragm. Ascending aorta is coming right off of the heart leading into the aortic arch. Remember BCS, brachiocephalic, left common carotid, left subclavian. Those are the three branches off of the arch of the aorta. You get it? BCS, brachiocephalic, left common carotid, left subclavian. Right common carotid and right subclavian come off of the brachiocephalic. Vertebral artery is going through your transverse foramen.
Can you repeat what you just said about the?
I know.
I'm just getting too excited.
Could you keep eating those popcorns? They're like high fructose corn syrup.
I know, the high fructose corn syrup is
Plus
good.
however much
You need to
coffee
eat
is in.
nuts or cheese or some herbal tea.
With lavender.
He loves sugar. I love
Oh, I'm like bouncing off the walls right now. And maybe that's why I love these things. They're all
What's the ingredients?
You're not supposed to
Sugar,
eat
high
that many in
fructose
like 10
corn
minutes.
syrup.
I don't think you're supposed to eat them like that. But I don't know.
It's
But
kind
I'm having a good time. Okay, where do we start again? Okay, BCS,
Yes.
brachiocephalic, left common carotid, and left subclavian.
And that is what? comes
Three
off of the
branches
aorta.
off of the arch of the aorta. Can you imagine if I was doing Red Bull
Please don't.
Oh,
my God.
You don't have to worry about that. So brachiocephalic, left common carotid, left subclavian, 3 branches off of the arch of the aorta.
Okay.
BCS. Brachiocephalic, left common carotid, left subclavian. Brachiocephalic splits off into the right common carotid and right subclavian.
Wait, I just missed it. It's this.
So we're back to the arteries.
This breaks up. Okay.
These are arteries.
That's all I'm
Right.
saying. Brachiocephalic goes up the aorta, left subclavian, left common carotid.
We need
Off
to
of the
know all of them.
brachiocephalic, this and
All the
this.
ones I just
Two
mentioned, yeah.
here.
Okay.
BCS goes after that?
Brachiocephalic, left common carotid,
No,
left.
After that.
The brachiocephalic splits off into the right common carotid and right subclavian.
Oh, not this.
Yay? Now, don't forget that the vertebral artery goes through the transverse foramen. You tend to see questions on lab exams. They'll show you a red vessel that's traveling through transverse foramen and say, what is this? And it's supposed to jog your memory from last semester that you got a transverse foramen. So if you've got a blood vessel going through that, it's a vertebral artery. Vertebral arteries go through the transverse foramen of cervical vertebrae. Oh, yes, they do. Uh-huh. See, I do need these cough drops.
But you're not supposed to eat it every time you cough.
Try to have a good time. May we chug on?
Sure.
Our common carotid, traveling up the side of the neck, it separates into an internal and external carotid. The internal goes to the brain, external goes to the structures on the surface of the face.
Wait.
Right?
But, right and left.
Okay, internal goes
To
to
the brain.
Both left
Yes.
and right.
Yep.
and external goes to what?
External goes to the structure, superficial structures, for the face. That part's good. May we chug along? In the arms and shoulder, the subclavian goes under the armpit, the clavicle. That leads to the armpit, which means it's the axillary artery. Don't worry about circumflex arteries or the deep brachial. The brachial is running down the center of the arm. And then in the forearm, the radial artery on the thumb side, ulnar on the pinky side.
Do we need to know?
PU, pinky ulnar.
Do we need to know the palmar arch?
And you want to know the palmar arch as well.
That would be the deep though, right? Under palm.
Superficial, remember, because if you are in, deep is on this side. If you're in anatomical position, this is superficial. Yes, don't forget about the anatomical position.
getting me giggles.
completely opposite.
And the ulnar artery goes into the carpal tunnel.
Carpal tunnel has got various ligaments and whatnot, or tendons going through it, and a nerve. I don't know if it's got, I don't think it's got a blood vessel. I don't know what else goes
But
through
the
it.
way it looks like the ulnar, I mean, yeah, it's more on the ulnar side, but it also looks like it's going a little medial.
Carpal tunnel, I'm getting, is gonna be more like maybe around this area right
Yeah.
here.
But the artery is very close to it.
But that's not wrong.
I don't think there's a blood vessel in the carpal tunnel, but I could be wrong. Let me see if my thing will fail me once again.
It's more just nerves, right?
I thought it was just like nerves and tendons. Ooh,
I'm just gonna move backwards. Give us
and of course, this thing doesn't help me.
Google probably would.
Yeah, I'd have to Google. I think it's just the median nerve and the several tendons. If memory serves me correctly. Very good question. Now, are we ready to go on to the next lovely slide?
Sure.
Having a good time. Ah,
CSI.
yes. So, abdominal aorta, the first unpaired vessel off of the abdominal aorta is the celiac trunk, going to stomach, spleen, and liver. Yes, the stomach, spleen, and liver. Superior mesenteric artery directly below it and right next to, relatively speaking, your renal arteries. Below that, on either side, you've got the two gonadal arteries left and right. And then finally, you have the last unpaired major vessel off of the abdominal aorta, inferior mesenteric artery. You look like you got a question.
Nah, I just.
No, not you, him. Oh, you're all set? Oh, good. I see everyone's with their faces, they're all concentrating, they're like. And beautiful picture.
I had to draw it.
So we're gonna need to know the gonadal artery for the lab, or?
I've never seen those asked, but you definitely want to know the mesenterics and the celiac trunk and the renals.
Okay, I was gonna say, I don't think we even looked
Yeah.
at those last time, so.
Sometimes just telling you what ones are good, because then if you don't need to know them, you know, rather than just leaving it unnamed, and then when you're looking at it on a test, you're like, well, what the heck is this? Do I need to know it or not? Are we all good so far? No, I'm not in any rush, so we're doing well.
Where's the, would you be able to see the gastric, left gastric of the celiac trunk?
It's cut off too soon, but you'll have to see it on the next picture somewhere around here. We'll hear, yes.
Okay.
Okay, but
All good? Whoa. Okay, so superior mesenteric is gonna actually supply your small intestines and ascending and descending colon, as well as, ascending and transverse colon. Inferior mesenteric, the descending colon and rectum. So that's your mesenterics in all their glory. So superior mesenteric, small intestine, and ascending and transverse colon. Ascending colon up the right side, transverse across the middle, descending down the left.
Repeat that one more time.
ascending colon up the right side, transverse across the middle, descending down the left side. So up the right, across, down the left. That's how the colon goes. So up the right, across the middle, down the left.
Like on our bodies on the right?
Right.
Oh, so on here it's left, that's ascending.
So here would be my ascending colon, then transverse, and then descending. Yes.
If you get colon cancer in the ascending colon versus getting it in the, what's this one called? The one that goes in, no, descending. Why is it have a poor prognosis?
Which one now?
Ascending.
My guess is that ascending would tend to be harder to diagnose. It's diagnosed later. That's my guess. Descending colon cancers, you're more likely to see.
Because of symptoms, lack of
symptoms,
symptoms, right?
Right, you're more likely to see problems with like blood in the stool,
On the
constipation, things
other
of that sort.
side.
Whereas if it's all the way on the right side, I think you're gonna be harder to detect symptoms.
So maybe it progresses before you have symptoms.
Why, do you unfortunately know someone
Yes.
that? How old?
But anyway, it was when they, it's not a good story, but, when they talked about side, they pointed out the side, and I just was wondering why one side would be like
I
more.
think actually, I think typically like 25% of cancers are in the descending and 25 are in the ascending and 25 are transverse. I think they're equally distributed everywhere. It's just that depending on where it is, you're more likely to see symptoms and discover it more quickly.
Right, like if it was on this side, you'd probably have more symptoms.
Yeah. On the left side, like sigmoid colon area, which here's the sigmoid right over here, the S-shaped area. You're more likely to see constipation or other altered bowel function and whatnot. And that's gonna hopefully clue you in something's amiss. This lovely picture, dear God, if you see a blood vessel coming off of or near the stomach, just say gastric artery. There's a left and a right. I'm not splitting hairs. Don't worry.
Where's that one?
Right around here. Here, running along the outer and inner curves of the stomach.
So is that number?
So 2 is the left gastric artery. It's all the way over here. And then, we have a short gastric artery. No, it's like overkill. If you see a red vessel going to the spleen, it's going to be the splenic artery. Now, here's the splenic artery, but you would see the spleen over here. So you wouldn't have to identify this unless you actually saw it going to the spleen. So if you see a red vessel going to the spleen, you know it's the splenic artery. If you see a red vessel going, here's spleen. Here's the red vessel, splenic artery. If you see a red vessel going straight to the liver, that's hepatic artery. Okay? Giggle. So if it's red and it's going to the liver, say hepatic artery. If it's red and it's going to the spleen, say splenic artery. If it's red and it's associated with the stomach, just say gastric artery and hepatic. Don't worry about these other crazy ones like the right gastroepiploic and whatnot. I couldn't get rid of those on the slide, so I just do that.
Wait, what's the one that's just gastric?
There's actually a left gastric and there's several others, but if you just see it associated with the stomach and say gastric, I'm happy.
Where is it on there? No, not that picture, the guy.
Here, I'm not even sure because they removed the stomach, so,
Oh.
it'll be right here.
Off the celiac trunk.
This top one up here. Because the other 2 are going to liver and spleen, so the third one's going to the stomach.
Gastric artery.
What did you say the liver artery was again?
Hepatic. Yay. Yay.
Yeah.
And here's just another picture showing you all sorts of fun with the superior mesenteric. anytime you have a blockage of blood flow to the intestine, you see massive pain. Not a fun thing. You can cut the intestines and you feel virtually nothing. But if you deprive the intestines of oxygen, oh God, you're gonna know it.
Is that what's happening in women when they have cramps?
No, but what can happen is if, and I had a student with this, if you get abdominal surgery, one of the problems is you're more prone to having parts of the bowel twist in on themselves. And if that happens, they've got to do emergency surgery to relieve that twisting, because if they don't, that part of the bowel is going to get strangled and it's going to be gangrenous and it'll kill you.
Because nothing will be released.
Oh, right, and it's going to cut off the blood flow. So that
They
area
just
is going to die.
untwist it? They untwist it, or you have to cut it?
Well, it depends on how bad it is. It also depends on how likely the individual is to make scar tissue inside their abdomen. Like this student of mine a few years ago, he walked the Appalachian Trail and in the process lost about 15, 20 pounds. And they think that was the reason why it caused a change in all the fascia and everything inside his abdomen. And that caused the first bowel twisting that needed a surgery. And then after that, he had scar tissue issues. So he's had a total of about like 5 surgeries in the past like 5-6 years. So in fact, he was in my AP2 class, and he actually had surgery over the weekend and then came back and took the test on a Tuesday and did better than everyone else. I was very, very proud of him. That's a
Come
true.
on, he's getting tested every single day of his life. He knows the body more than anybody else, because he has to.
Well, not fun. Not fun for the poor guy. So, and they've tried all sorts of different types of operation techniques to reduce the amount of twisting and whatnot, but for whatever reason, he's just prone to that. From what I've heard, horses and German Shepherds are also prone to dying because of the bowel twisting in as they get older. So,
Yeah.
it's just one of those things that happens. So it's not fun.
So what's happening in women? Cramps.
Cramps? I would say maybe like period cramps.
Yeah, it's just muscle? It's just
That's your prostaglandins that are causing issues.
We'll come back to that.
We'll-
Because
we'll
it's
cross it.
projected.
It's prostaglandins. Huh? Go on. Here is our lovely common iliac coming off of the abdominal aorta and then breaking off into the external and internal iliac. Internal iliac feeds organs in the deep abdominal cavity, or I should say deep pelvic cavity. And then the external iliac, once it crosses the inguinal canal, it goes into the thigh and splits into the, turns into the femoral artery. Don't worry about the medial circumflex and all these other things. The femoral artery just goes down the thigh. Behind the knee, it's the popliteal artery. It goes through the adductor hiatus. A hiatus is a passageway. So the adductor hiatus is a passageway for the femoral artery before it turns into the popliteal.
So which ones do we not have to worry about?
You don't have to worry about like the median and lateral circumflex femoral arteries and deep femoral artery. Don't worry, and the gluteal artery. Don't worry about that. So just know common iliac to external and internal iliac. External iliac goes into femoral, femoral to popliteal, behind the knee. Then I split into an anterior and posterior tibial artery. And then dorsalis pedis at the top of the footsie.
This is all for lab. We're not gonna have to say like, oh, the femoral artery goes through the adductor hiatus into the popliteal.
No, I just throwing out hiatus. I wanted to define hiatus because that's going to be important with the diaphragm. You've got 3 passageways with the diaphragm, one for the esophagus and then one for the vena cava and one for the aorta. So if you have a piece of the stomach pumping, pushing up through the hiatus for the esophagus, that's a hiatal hernia. Yay?
What's the best way to differentiate the anterior and posterior tibia?
You wanna look at how dark the color is. The darker the color, the more superficial it is. So anterior tibial from this side will be dark red, whereas the posterior tibial is much lighter in color.
Posterior would be like the back,
Right,
half.
the back, right. Yeah. Yay. So far, so good? So again, this is looking at the leg from the backside. So you see the posterior tibial in this case is actually a brighter red because he's in front now in this perspective. The anterior disappears quickly over here, so they don't really show it. There's a fibular artery. I'm not going to ask you that, but it's on the side of the fibula. Your plantar arch is in the part of the foot that actually touches the ground. Don't worry about the medial plantar artery and the lateral plantar artery. Don't worry about that. Once again, popliteal behind the knee. Oh yeah, this is a fantastic experience.
No,
5 minutes left.
Yeah. That's what we like.
Yes, Victoria. Did she text me to say she wasn't gonna be here? Oh,
Are you gonna ask us about the circle of Willis and the intercommunicating?
the circle of Willis you'd like to know, but that I think is put out here somewhere. Again.
Didn't we do it last week?
Well, they put out, I had the screen just to get this stuff out here. They had this set up for the lymphatics lab, and I was saying, wait a minute, we have the lymphatics lab next week, and they're like, oh, we forgot about that. I'm like, yeah. So we finally, oh, here's Circle of Willis. I knew if I could one card, I'd find it. So Circle of Willis is this area right in here that you would like to be familiar with.
For the brain.
Yeah, the base of the brain.
Do we have to know like the communicating with cerebral?
As long as you said Circle of Willis, I'm happy.
Okay.
I am not
A few
hard.
hours are
I'm
gonna go.
not hard to please. Circle of Willis. Okay. What else we got in this grand scheme of things? Dural venous sinuses. We'll talk about this in lab, but remember a sinus, now we're into veins. Sinus doesn't have any smooth muscle in its vessel wall. So these are vessels within the skull, on top of the brain. So like we have a superior sagittal sinus, an inferior sagittal sinus, a straight sinus, things like that. Really, the one I see asked on a test is a superior sagittal.
And that's A.
That would be A.
No smooth muscle, right? Is that what we said?
No smooth muscle in the wall.
Superior, and how about straight sinus or transverse?
Let me see what the other ones here I didn't include. I had a picture here. Ooh. Aha. So superior sagittal sinus is this. Inferior would be this. This guy that is the straight sinus over here, if you're interested.
It's called the straight
The
sinus.
straight
Which one?
sinus.
Where's that
B.
one?
B.
Okay.
That's just FYI though.
You got a sigmoid sinus in here around somewhere. This looks a little bit different than the picture I have in here, but I mean,
That's just
they aren't going
FYI.
to ask those. They aren't going to ask those. As long as you do superior sagittal sinus, that's the one I'd like you to know.
I don't want to learn anything out here.
Yippee.
I don't. There's too much to know already.
Ooh. Jugulars. Now on our models here, where I got my red dot, you only see the internal jugular vein in the neck. You don't see the external. Here on this picture you see both. The internal is much larger. The external is a little bit more lateral to that and it's smaller. Some people, the internal and external jugulars join together to form a common jugular because everyone's different. You could even have a common jugular on one side but not the other. So that's weird, but it's possible. Just like some people have a Palmares lung, some people don't. So there's a lot more variation with the venous system. A lot more variation.
I don't have that.
Would you say the internal is like more medial?
Internal's more medial. Here you'll see external, lateral, internal, medial, but on these models you only see the internal jugulars.
That's the blue.
Right.
Mm-hmm.
The jugulars of the subclavian vein join to form the brachiocephalic vein. You have two brachiocephalic veins, but only one brachiocephalic artery. So keep that in mind. Brachiocephalic arteries on the right, but you have two brachiocephalic veins, although you're looking at that picture from the lateral side, so you only see one, but you do have two brachiocephalic veins, a left and a right. And just for ha-has, the left brachiocephalic vein is much bigger than the right brachiocephalic vein. It's just the way we're hooked up. But you do have a left and a
Would they
right.
show it like that in anatomical position or like this?
They could do lateral view or anatomical view. Yeah, lateral views are obnoxious, I agree. Yeah.
So the right subclavian joins the brachiocephalic.
Right subclavian and the both jugulars, everything leads into the brachiocephalic. And then that will eventually lead into your superior vena cava, which goes to the
No, I don't.
right atrium.
Is the left bigger because the left side is responsible for bringing the blood from the entire body?
Maybe. That's a good question. It just might be just the way that we're hooked up. Well, actually, no, that does make sense because you're carting much more blood. That could be, yeah, that could very well be. Could very well be. Because the right side, you're just getting the right side of the, yeah.
I don't know, God.
Yeah, 'cause yeah, this is all left side, and this little bit here is right side.
Should I publish this?
What the heck, man? I think it is time for us to take a break.